కానీ అందులో డ్రాప్ చేయాలి వాళ్ళకి కనిపించాలంటే. వాళ్ళకి కనిపిస్తుంది. ఇప్పుడు ఇప్పుడు లైవ్ అవుతుందండి. ఏంటండి చూడండి, ఇది వీడియో is restricted, please check your network. Okay. Hello everyone, I am Dr. Udhakiran, Senior Resident in Medicine Department. I will be taking GIT classes for 6th and 7th semester. So I will be coming every Tuesday to take this class at this time. I will be covering GIT. Today we will talk about liver. Okay, liver. First we'll cover liver, and then we'll go to intestine after we finish this. In liver, the most important thing for an undergraduate is to know about cirrhosis and its presentations. So liver disease can present in an acute way or in a chronic way. When it is an acute presentation, it presents as acute hepatitis. Acute hepatitis may lead to acute liver failure also. You know what is acute hepatitis? Acute hepatitis will present as abdominal pain, jaundice, nausea, vomiting. Acute presentation, any infection within last 10 days, 15 days will cause acute hepatitis. But whenever there is ongoing disease for so long as 5 years, 10 years without any clinical manifestation, it will lead to cirrhosis in the long term, which is also called chronic liver disease, which is a manifestation of cirrhosis of liver. So what is cirrhosis? We'll deal with the definition, but broadly what is cirrhosis is because of the chronic injury to the liver and chronic repair of the liver. After injury there will be repair of the liver, right? Regeneration, repair of the liver, there will be fibrous tissue deposited in the liver, and there will be parenchymal liver damage because of the pathology. If there is a liver damage, the liver parenchyma is lost and it is replaced with fibrosis. So it will lead to various manifestations. The first thing is because of the loss of liver parenchyma, there is a decrease in liver function. Liver has many functions like detoxification, excretion of bilirubin, synthesis of albumin, synthesis of coagulation factors, and synthesis of various inflammatory mediators also. So all this function is lost gradually by depending upon how much cirrhosis is there, how much parenchyma is lost. These functions are gradually lost. And the other thing, because of the fibrosis, the vascular channels are compressed and compromised. The portal vein, which drains the intestine into the liver, ends in hepatic sinusoids, right? Those hepatic sinusoids are compressed because of fibrosis, compressed, and it will lead to portal hypertension. So basically, you will have clinical features because of loss of liver parenchyma and fibrosis also. So these will have various manifestations like, you know, ascites, bleeding varices, and hepatic encephalopathy. So we'll be dealing about these things in detail, the definition, the clinical the etiologies of cirrhosis, the clinical manifestations, and the complications of cirrhosis. So in the next classes we'll be dealing about the complications in detail, like how ascites, how do you treat ascites, how do you do portal hypertension, how do you treat hepatic encephalopathy, everything. So right now we'll begin with cirrhosis. Cirrhosis is defined as chronic injury of the liver with leading to hepatic fibrosis. So what causes this fibrosis? Any insult to liver parenchyma will lead to activation of stellate cells and Kupffer cells. As you know, the stellate cells are present in the space of DC. What is the space of DC? There are hepatic sinusoids and hepatic parenchyma. In between there is a space where lies the Kupffer cells and stellate cells. Kupffer cells are nothing but macrophages residing in liver. So whenever somebody drinks alcohol, or there is an infection, or there is some drug or toxin that is causing activation of Kupffer cell and stellate cell, they transform and start depositing fibrous tissue around these sinusoids. So fibrous tissue, once fibrous tissue is deposited, more Kupffer cells will get activated when they come into contact with fibrosis, and it is a cycle. It will once your liver fibrosis starts, it goes on for life. You cannot stop it easily. As of now, maybe in future better medical treatments come, maybe we can stop. But right now, it is a chronic process. It will keep on going and will eventually lead to end-stage liver disease. So majorly, the injury results from hepatocyte necrosis, maybe because of infection, maybe because of toxin and all, and there is a collapse of the supporting reticular network, and there is connective tissue deposition and distorted vascular bed. As we have spoken, that sinusoids are compressed because of the fibrous tissue deposition, and because there is death of hepatocytes, the remaining hepatocytes regenerate. When they regenerate, they become nodular. They become nodular, and the whole they'll regenerate in the form of nodules separated by fibrous tissue. So all this will give you a nodular appearance to the liver. So as we have already seen that hepatic stellate cells and Kupffer cells are the cells that are majorly responsible for the deposition of fibrosis. And clinical features, like we have spoken just now in brief, the clinical features are majorly due to two things. One is due to loss of hepatocellular function. Like, what are the functions of hepatocellular? Speaking, it is majorly metabolism of hormones. Actually, steroid hormones like estrogen, testosterone, they are metabolized. Mostly estrogen, that is in the blood, is excreted, is metabolized and excreted into the bile. And similarly, bilirubin is excreted, and albumin is produced. Albumin, as you know, is needed to maintain the oncotic pressure in the blood vessels. Like, if there is albumin, your fluid will stay in the blood vessels. If the albumin is low, it will lead to movement of fluid outside the vascular bed. Water will move outside the blood vessels and lead to edema. As you would have already seen, cirrhosis patients will have pedal edema, ascites, everything. One of the causes for that is low albumin. So albumin is lost, and then your coagulation factors like 2, 7, 9, 10 coagulation factors are especially produced by liver, and you lose that also, and because of that there is a coagulopathy. And there are many metabolic abnormalities, acid base abnormalities are there, lactate, urea, all these are metabolized by liver. You will have similar metabolic abnormalities. And second thing, these are all metabolic derangements. And the second thing is to physical, that is like compression of portal veins, sinusoids will lead to increase in pressures and lead to portal hypertension. And portal hypertension will lead to gastroesophageal varices, splenomegaly, and ascites. So etiologically, how do you classify cirrhosis? That you can classify it by etiology, you can classify it by pathology. If you look at pathology, you call it as like on a slide and a macroscopic view or microscopic view, macronodular or micronodular cirrhosis. That is how you classify pathologically. Micronodular cirrhosis, there are small nodules or small regenerative nodules separated by fibrosis. Macronodular nodules are cirrhosis is big nodules you will be feeling. You can actually feel it when you palpate. You can feel nodular texture when you palpate for the liver. So why these happen? One is why micronodular, the other is why is it macronodular. If there is slow, ongoing, continuous destruction of liver tissue, the regenerative nodules will be small and many. If there is sudden destruction, sudden bouts of destruction followed by some latent period, again bouts of destruction, the destruction is more, then the regenerative nodule also will be big. You will give a lot of time for it to regenerate. So this is how micro and macronodular cirrhosis. The pathophysiology is not clearly defined, like why something happens as macro and why something happens as micro, but this is how it is classified pathologically. Etiological classification is very important for us because there are some 7-8 important causes of cirrhosis, and you need to know them. So you can, whenever some patient comes with cirrhosis, you need to investigate what is the cause of this so that you can treat. So most important thing is the most important cause of cirrhosis is alcohol worldwide. It almost amount to some 40-50% in our country, and in other countries it will almost amount to 70-80% where alcohol consumption is more. The next thing is post-necrotic, not post-hepatitic, post-necrotic you can call it, post-necrotic cirrhosis. That is because there is death of liver tissue because of some drug you have taken which is toxic to the liver, or hepatitis A, B, all this kind, which will result in immediate injury to the liver. This is called post-hepatic necrosis. The third thing is biliary necrosis, biliary cirrhosis. See, bile is very toxic to the liver, to any tissue actually. It is used in digestion of fats, right? So whenever it comes into contact, whenever it is left in any tissue, deposited in any tissue, it will digest the cell membrane, it will cause injury to that particular tissue. Intestine has separate protective mechanisms from this bile, but if it goes anywhere beyond intestine, it will be dangerous to the tissue. So whenever there is obstruction of that biliary pathway, it can be bile duct, it can be intrahepatic bile ducts, or it can be hepatitis alone, resulting in the disruption of that biliary architecture. All this will lead to retention of bile in the liver, and that will cause tissue damage and cirrhosis. It's very bad actually. It's very severe also. So what are the causes of biliary cirrhosis? What are the causes? Usually when there is a long-standing obstruction, like primary sclerosing cholangitis, you call it, when the bile duct is autoimmune disease of the bile duct causing compression of the bile duct, primary biliary cirrhosis, or chronic cholestasis because of some stones, or cystosomiasis blocking the gallbladder bile duct, it will cause that. The other thing is cardiac cirrhosis. Cardiac cirrhosis is whenever there is cardiac failure, there is increased venous pressure, right? The heart cannot pump blood forward, so there is venous stasis. This venous stasis will lead to increase in inferior vena cava, and hence hepatic vein. The increased stasis and venous pressure will lead to fibrous Kupffer cell activation and lead to fibrosis of the liver. Okay. The others are metabolic. Many metabolic, like there are so many metabolic diseases. The liver is the site for many metabolic processes like urea cycle, glycogen storage disorders, alpha-1 antitrypsin deficiency, hemochromatosis, most importantly, Wilson disease, iron, copper, everything. They can cause cirrhosis because of their deposition. So this is the etiological classification. Whenever some patient comes, we'll go according to this orders. When some cirrhosis patient presents to you, we will check accordingly. Is there alcohol history? Is there any hepatitis infection? We'll check for it. Is there any cholestasis? Heart failure? In that order, we'll check to find out the etiology so that they can be treated. There are other infections, like we have seen infectious causes of cirrhosis. Like most important is viral hepatitis for undergraduate level. There are other infections that you can see later. So drugs and toxins are also most important. These come in post-necrotic. We have seen alcoholic cirrhosis, post-necrotic cirrhosis, biliary cirrhosis, and cardiac cirrhosis. Drugs and toxins most importantly come under post-necrotic. Acute drugs, because of the toxicity, will cause necrosis, and then it will lead to cirrhosis. Alcohol, they are regarded as one of the drugs, but most important are amiodarone. There are other drugs like methotrexate and all. So these are the metabolic causes. As I told you, there are so many metabolic pathways undergoing in the liver. So these are some of these. Of these, most important for us is hemochromatosis, and the other one is Wilson's disease. Wilson's disease is because of deposition of copper in the liver. Hemochromatosis is because of iron deposition in the liver. These are others. You need not care about this much at undergraduate level. So signs and symptoms. As we have seen, the major derangements in the okay. So when you talk about signs and symptoms of cirrhosis, we have seen one is the metabolic derangements leading to symptoms, and the other one is portal hypertension. So when you come to metabolic derangements, the most important thing is loss of excretion of bilirubin. So bilirubin is conjugated by liver so that it is better soluble in bile, and that way it is excreted. So what is lost is the glucuronidation of bilirubin. Bilirubin should be conjugated with glucuronide so that it is easily excreted. That is lost, and so bilirubin will be left in the blood. It cannot be excreted properly. That's why you see jaundice. So this what kind of jaundice you see? In hepatitis, there is loss of function of conjugation. So you will see unconjugated bilirubin. But whenever the liver architecture is also gone, the biliary architecture is also gone, and bile ducts are compressed, whatever that is conjugated is also not excreted into the bile. So you can have both conjugated and unconjugated bilirubinemia, depending upon which component is more. If hepatitis component is more, loss of parenchyma is more, you will have unconjugated. If cholestatic function is like biliary ducts are compromised more, you will have conjugated bilirubinemia. That is the first thing you will see icterus. That is how the patient presents with jaundice actually. And it also depends on etiology. If it is because of cholestasis like primary biliary cirrhosis, primary sclerosing cholangitis, you will have more of unconjugated. If it is viral hepatitis like hepatocellular parenchyma is infected and it is getting damaged, you will have more of unconjugated. So first thing is bilirubin. Second thing, what else is lost? That metabolism of estrogen is lost. Estrogen will cause you mostly like vasodilation. If estrogen is accumulated in blood, you will have vasodilation. They say when women have that is how they depict in the dolls, in the movies and all. Women have red cheeks. They even paint them like that. Why? Because the estrogen causes vasodilation and gives you skin reddish color. So what happens now? Even in men, whenever there is the cirrhosis, that estrogen is not metabolized. Even in men, there is estrogen. In peripheral tissue, some amount of adrenal estrogen is converted into more potent estrogen in the peripheral body, in the body fat. That is usually metabolized by liver. Now it is lost. So there is increased estrogen in the blood. That will lead to vasodilation everywhere. Like the palms are more red, palmar erythema. Okay, and blood vessels are dilated. You call them a spider angiomata. It is like a spider. There will be a center arteriole by peripheral blood vessels. The whole things are by dilated blood vessels. You can see on the upper chest actually. There are spider angioma, and that these are all because of deposition, increased estrogen in the blood. And there is one more thing, gynecomastia in men, obviously because of estrogen, and loss of hair in axilla, in pubis. All these are because of male hormones. Now female hormones are increased, so you'll be losing axillary hair, pubic hair, and there will be decrease in libido also. Then there are no longer male hormones dominating, female hormones are dominating now. That is because of, all these are because of estrogen increase. The other thing is, like you have seen, anorexia and malnutrition, fatigue, malaise, all these are because any chronic inflammatory process going on in the blood, in the body, and any liver damage will lead to these symptoms. The foremost symptom is fatigue, malaise. Any liver disease will cause these symptoms. And importantly, alcoholics will have parotid gland enlargement. That is one important thing. The mechanism is not properly known, but there is parotid gland enlargement. And obviously, like easy bruising, that is because of loss of some metabolism, connective tissue metabolism and all. And in women what happens is like that estrogen levels are altered. And one more thing, whatever testosterone is present in women is also not metabolized properly, because liver metabolizes and excretes all these steroid hormones. So that happens for them, virilization, menstrual abnormalities, and diputeraneous contraction. This is very important. You can see directly in a patient, like patient will have flexion of their palm like this, diputeraneous contraction. Okay, did I miss anything else in this? Clubbing of player and splenomegaly. Why splenomegaly? Oh no, till now I talked about metabolic things, right? Now it is because of next part is because of portal hypertension. Portal hypertension will lead to, is essentially like increased pressure within the portal vein, leading to stasis of blood. So what happens? Where does this portal blood arise from? One is spleen and the other is intestine. Whenever the splenic pressure is increased, the splenic stagnation of blood happens in the spleen, and the spleen will get enlarged. So any enlargement in spleen results in thrombocytopenia. Spleen will effectually phagocyte all the platelets. Platelets are captured within the spleen and will have thrombocytopenia also. So there is splenomegaly, and then because of the increase in pressure, now what happens? See, there is increased hydrostatic pressure within the hepatic sinusoids because there is fibrosis. Downstream of it, there is increased pressure. Because of the pressure, more amount of fluid escapes the sinusoids now. What is this fluid? It is called lymph. Whenever blood fluid escapes from the blood vessel, it is called as lymph. So all this fluid, there is massive amount of fluid that is escaping because of the increased pressure. So this fluid eventually will drain from the lymphatics and it will come into your abdomen. That is called as ascites. So this is how there are two mechanisms. Most important is increased lymph production from the sinusoids that will be deposited as ascites. Not you need not say lymph. It is just fluid escaping. You can say that. If you say lymph, it will become chyle. Actually, that we will not talk about it. And another part is decreased albumin production also. Decreased albumin production will lead to decreased oncotic pressure and fluid escapes the blood vessels. That's why you see pedal edema. But the ascites component is because of increased escape of fluid from the sinusoids. And the third thing, one is we have spoken splenomegaly. All this is because of portal hypertension. Splenomegaly, ascites. The third thing is bleeding esophageal varices. What are these varices and why do they arise? So whenever there is increased portal venous pressure, this blood tries to go through some other place where there is less resistance to its flow. So as you know, the whole intestine is from stomach to your rectum. The blood drains into portal tract. From the esophagus and upwards, it will drain into superior vena cava, and legs and all will drain into inferior vena cava. So whenever there is obstruction to the portal blood flow, this blood tries to go through some other channel, like it wants to go through esophagus, blood vessels in esophagus where the resistance is low, or it wants to go into pelvis, which drains into inferior vena cava. So what essentially happens, wherever these two systemic and portal veins are overlapping, some areas like see upper border of the stomach, there are systemic blood vessels from the esophagus, veins from the esophagus, which eventually drain into esophagus and superior vena cava. And there are the celiac venous plexus that will drain into portal tract. So instead of going down into the portal tract, this blood finds an easy way into the esophagus. So there the blood flow increases from the whole portal tract. Blood gets diverted now through these channels into the esophagus. Similarly, near the rectum also, blood will get diverted towards the rectal vessels and through the inferior vena cava it wants to escape into heart. And one more thing, you call it caput medusae. You must have heard caput medusae, right? Umbilicus, the ligamentum teres, which is the vestigial umbilical vein. Now it gets opened, blood comes back from the liver near the abdomen, and from the abdomen it goes through the skin blood vessels. From around the umbilicus there are blood vessels. Through the skin they want to go up or down. In every way they go away from the umbilicus. It's called like caput medusae, we call it, because it's like a hair. The medusa will have hair radiating all around head. You can see the picture of medusa on web. That is how it is. So blood, essentially what it is doing, it is coming back from the liver through the vestigial umbilical vein and draining down into inferior epigastric and inferior vena cava. Going up into superior epigastric, azygos vein and superior vena cava. So it's going upwards and downwards. It's going essentially away from the umbilicus. That is caput medusa. So we'll see varices at around esophagus, umbilicus and around rectum. These are all varices, and when the blood flow is more, they get dilated and there is a chance of rupture and bleeding. So these are all clinical parameters. Like we have seen, one is metabolic, the other is due to portal hypertension. These are clinical features that you can see. Somebody can present with hematemesis because of the ruptured blood vessels. Somebody can present with melena or hematochezia because of the anal varices, or jaundice. And one more most important thing is hepatic encephalopathy also. All these toxins, mercaptans, all these are not metabolized in blood anymore. Ammonia gets increased in the blood, which has to be metabolized by liver. Ammonia is metabolized by liver, converted into urea and excreted. Now it doesn't happen. So ammonia gets deposited in the brain and it will lead to hepatic encephalopathy. We'll speak about it in detail when we are dealing with complications in the next class. So signs and symptoms. What are the signs and symptoms? Like we have seen splenomegaly, ascites. This is all you elicit, right? That's why it's called a sign. Patient will not come and tell I have splenomegaly. You will have to see it. Whenever you do blood parameters, you investigate the patient. You check for albumin. Albumin is low. There is prolonged PT because of the loss of clotting factors. And this is important. Aminotransferase and alkaline phosphatases are elevated. What are aminotransferases? These are the enzymes present in the liver cell hepatocyte. Whenever there is injury, these get released into the blood. So when we check for them, these levels are elevated in the blood. Alkaline phosphatase is increased whenever there is cholestasis. Aminotransferase when there is increased parenchymatous injury. Both these happen in different proportions in different causes of cirrhosis. There may be hepatomegaly because of nodular regeneration and increased size of nodules. Encephalopathy can be present, like I said, because of ammonia increase in the blood. So how do you evaluate a patient with cirrhosis? Somebody has come to you, there is jaundice, there is abdominal distension, there is history of alcohol consumption, or there is there may be, so this such a patient comes to you, pedal edema, cirrhosis, jaundice, and this patient comes. How do you evaluate? First of all, you need to find out if there is cirrhosis or not, if it is cirrhosis or not. And second thing, you need to find if there are complications of cirrhosis. And then you'll go for etiology. What is the cause of this cirrhosis so that you can treat it? So how do you do it? Liver function tests. What are liver function tests? AST, ALT, alkaline phosphatase, bilirubin. All this you do. And coagulation tests, serum albumin. All this you do. Next is is there any? Actually, these are derangements of liver function. Is there physically any cirrhosis? Is that liver tissue having fibrosis? So that you will do an ultrasound. Ultrasound can reliably demarcate if there is cirrhosis. Now you will do upper GI endoscopy. So cirrhosis is there now. You will see, have seen splenomegaly, hepatomegaly in ultrasound. You want to know if there are any bleeding varices in the esophagus. So you will do an endoscopy, see if there are any varices in the esophagogastric junction. And finally, you want to do a liver biopsy. Why do you want to do a liver biopsy? Because you want to see a fibrosis and how severe is the fibrosis under a microscope. So this is how you evaluate the patient. So you have, now that you have decided there is cirrhosis, there are complications of it, and you want to know the etiology of it. Now what do you do? Like just a minute. So in etiology, now you will the slide is missing actually. So now whenever you want to check for etiology, first thing you'll anyway ask for alcohol. The patient will give you a history. You don't need any test for that. But when you suspect hepatitis, you'll check for hepatitis A, B, C, D, E. A and E cause acute hepatitis. B, C are notorious for causing cirrhosis. We'll check for various serological parameters. We'll discuss about when we are discussing viral hepatitis. And then comes your biliary cirrhosis. Whenever there is alkaline phosphatase and all elevation, you will think more in the lines of cholestasis, and you'll think about primary sclerosing cholangitis or primary biliary cirrhosis. And the next thing is cardiac cirrhosis. We'll do an echo. We'll see how the heart is functioning, if it is pumping properly or not. And if there is heart failure, that might be the cause of cholestasis. And we'll ask for any history of recent intake of drugs or something. So that and most importantly, whenever we come for metabolic parameters, we'll see if there is any hemochromatosis. Whenever there you suspect hemochromatosis, you see, let's check blood iron levels, ferritin, transferrin saturation, that you will check. Wilson's diseases, serum ceruloplasmin, and all that we'll be discussing later. So copper levels, iron levels also will be checking. There are other rare diseases like alpha-1 antitrypsin deficiency, some urea cycle abnormalities and all. That is not for undergraduate level. So that's about it. So further thing is like you will be checking for complications and all. So management of cirrhosis and complications of cirrhosis. How do you manage each complication? We'll be discussing in the next class. Okay. Thank you.